Good afternoon and welcome to the Rural Emergency Hospital Educational Webinar. We are so excited to have two REH leaders with us today to discuss their experiences. We do have a packed agenda and we're going to start with giving you a brief overview. If you've joined us before, you may have seen some of this information, but if you're not familiar with the REH designation, we're going to go over at a high level the policies and requirements of being an REH. We're going to talk a little bit about the Rural Health Redesign Center and the technical assistance that's available. Anna will be leading the discussion with our REH leaders. And then we will close out our session today with resources and next steps. Before we get started, I want to go over a few housekeeping items. You may notice that everyone is on mute. This is to avoid background noise. When possible, we ask that you use your webinar link to log in rather than the call-in option. This will ensure that you have the best audio quality experience. We encourage you to ask questions. Please feel free to use the Q&A feature. You'll find that at the top or bottom of your screen, depending on your layout. And if you need closed captioning, it is available. To access it, click More with the three dots at the top of the screen, and then select Language and Speech, and choose Transcription for closed captioning. The slides and recording for this webinar will be available on our website at rhrco.org within a week after today's event. If you have any follow-up questions, please reach out to us at rehsupport@rhrco.org. My name is Amy Kaltenbach, and I'm a project manager here at the RHRC, supporting the Rural Emergency Hospital Technical Assistance Center, and I will be your moderator. And as a brief introduction to our presenter, Anna. Anna is the Chief Administrative Officer here at the Rural Health Redesign Center. She's a transformational leader and registered nurse with 30 years of experience in rural healthcare. In her previous role as REH Program Director, Anna worked directly with hospitals throughout the country who were exploring the rural emergency hospital as a possible pathway to maintain healthcare in their communities. Anna has held positions in hospital leadership for over 25 years, with roles that include Chief Nursing Officer and Chief Executive Officer. Anna holds a master's degree in healthcare administration and is a board-certified nurse executive. Now to introduce our REH leaders. Aaron Herbal is the Chief Executive of Mercy Hospital in Moundridge, Kansas. He served as administrator since April of 2017 and is CFO since February of 2019. He leads the facility in meeting the healthcare needs of the community by exempling compassionate leadership. He piloted the organization through the COVID-19 pandemic and through several years of financial uncertainty. A chief accomplishment has been the successful transition to the new rural emergency hospital model in early 2024 to ensure the financial sustainability of the organization. In his spare time, Aaron enjoys reading, writing, traveling, and spending time with his wife and 4 children. And Annette Schnabel. She's the president at Parkland Health Center at Farmington and Bonne Terre. She holds a doctorate degree in physical therapy and a master's degree in business administration. She's a member of the American Physical Therapy Association and a fellow of the American College of Healthcare Executives. She belongs to the Rotary Club, the Farmington Industrial Development Association, the Mineral Area College Foundation Board, and is an ad hoc member of the Farmington Chamber. Previously to coming to Parkland Health Center, she had served in healthcare leadership positions. Now I'll turn our presentation over to Anna.
Thank you, Amy. Good afternoon, and thank you all for joining us today. It's a pleasure to be with you and have this opportunity to share with you our work at the Rural Emergency Hospital Technical Assistance Center. First, I'd like to introduce the Rural Health Redesign Center, and our mission is to protect and promote access to quality health care in rural communities across our country, with a vision to help rural communities thrive through improved health. This work is accomplished through our various programs and work with rural leaders in rural communities across the country. So at the Rural Emergency Hospital Technical Assistance Center, we work to inform interested hospitals on the eligibility criteria, the payment structure, and the application process for the Rural Emergency Hospital designation. The REH is a new Medicare designation that was established through the Consolidated Appropriations Act of 2021 and became effective January of 2023. And since that time, 41 hospitals across the country have converted to a rural emergency hospital. Our work at the REH TAC, as we refer to it, is in cooperation with HRSA, the state offices of rural health, and hospital associations, as well as hospital leaders who express a desire to learn more about what the REH designation would mean for them and for their communities. As hospitals reach out and request technical assistance, we take each participating hospital through an educational process that includes the REH specific requirements, the conditions of participation, the application process, and the financial modeling is provided to each individual hospital to truly demonstrate the impact of what an REH conversion would have on that individual hospital. At the beginning of the TA process, we match each hospital with one of our provider liaisons or subject matter experts. Each of our experts have extensive rural relevant healthcare experience. The provider liaisons partner with the hospitals and support them through the technical assistance process. And that includes one-on-one tactical conversations during each step of this process. Financial modeling is provided, and once completed to the satisfaction of each hospital leader, can assist them with their informed decision making. If a hospital determines that the REH is right for them, then application process support and planning is provided. For ongoing support, the partnership that began in the pre-conversion period is continued in the post-conversion program, which includes, again, one-on-one conversations and continued technical assistance based on the hospital's individual needs. We also have an REH peer group that meets monthly for shared learning and support. The REH Leader Forum meets the third Tuesday of every month and is open to all REH leaders. So the REH was established to truly avert potential hospital closures and to allow for continued access and provision of essential services within our rural communities. The REH provider type is a Medicare model that provides special payment flexibilities for Medicare fee-for-service only. This is not a temporary or a demonstration model. This designation does provide for a monthly facility payment, which we'll talk a little bit more about here in coming up in a few slides. To qualify to become a rural emergency hospital, there are some requirements. The hospital must be a licensed Medicare provider, either a critical access hospital or a rural PPS hospital with fewer than 50 beds. And that fewer than 50 beds must have been in effect on 12/27/2020 and also true at the time of application. They must meet state licensure requirements and maintain an annual average length of stay of less than 24 hours. They must meet and be in compliance with the Rural Emergency Hospital conditions of participation. And they will need to have a transfer agreement with either a level 1 or a level 2 trauma center. An action plan is required for the application process. We'll talk a little bit more about that also here in a little bit, but this will need to be completed and accompany the application. This action plan needs to describe staffing and services that will be provided at the rural emergency hospital. So there are some things that the rural emergency hospital must provide, and that includes 24/7 emergency and observation services, again, maintaining that annual average length of stay of less than 24 hours. They must provide diagnostic and radiological services to meet the needs of the patient population. They must have a pharmacy drug storage area, and they must provide discharge planning, which is overseen by a qualified professional. Again, the REHs do not provide inpatient care, but they would have agreements to transfer those patients to the facilities that can meet the needs of those individual patients. The REH model does allow for the provision of outpatient services, and the list in front of you is not an exhaustive list, but as you can see, they are still able to meet community healthcare needs through their outpatient services. The REH is still required to file cost reports. CMS established the REH Quality Reporting Program in calendar year 2024. There are 4 measures. One is a chart abstracted ED arrival to discharge measure, and the other 3 are claims-based, but those also need to be monitored and tracked. As previously mentioned, the REHs do have their own set of conditions of participation that they must ensure they are in compliance with to provide insurance that they are meeting the health and safety standards for their hospital. This slide talks about the payment rules. So the hospital converting to the REH will see some gains and some losses when looking at the payment rules. We'll talk about the losses first. So all inpatient services must be closed. All swing bed services must be closed. The REH may have a separate, distinct skilled nursing unit, but they must also meet all current day requirements for that. The REH is not eligible to participate in the 340B drug pricing program. And if the hospital was a critical access hospital, of course, they would lose their cost-based reimbursement. But if we move over to the other side and talk a little bit about the gains, the REH services paid under the OPPS system would receive a 5% bump up for those for the Medicare fee-for-service payments. The REH also would receive a monthly facility payment. It's a little bit over $3.4 million for 2025, and that amount increases yearly by the Medicare market basket amount. There are no changes made to the rural health clinic payment or the physician payment rates, which are paid under fee schedules. And again, just to touch upon the application requirements, there are certain steps that are needed to be followed for this application. The hospital must complete an 855A change of status. They will need to develop that action plan, which clearly describes the plan for transition to the rural emergency hospital. This needs to include information about staffing, the services that they'll continue, the services that would be discontinued, which again would include the swing bed services and the inpatient care. Any services that are going to be added or modified will also need to be spelled out in that action plan. The application process also requires an attestation form, and that attestation form is stating that the hospital is in compliance with their current conditions of participation and will be in compliance with the rural emergency hospital conditions of participation. Along with that application, the copy of the transfer agreement with either the level 1 or the level 2 trauma center also has to accompany that application. So we at the REH Technical Assistance Center are poised to assist hospitals through each of those phases, through the exploration, the decision-making process, and the application process, and then also to continue that partnership in the post-conversion period as well. I know that was very quick, but we have some very valuable guests with us today, and I'd really love for you all to hear their input and their insights and experience from their journey to become an REH. All right, so thank you, Annette and Aaron, for being with us here today. And I'm just going to start asking you some questions so the audience can get an impression of your journey and what that has looked like for you. So starting with Annette, can you walk us through the decision-making process for your hospital to become an REH?
Thank you. So we started actually internal discussions to, once we saw the regulations that were associated with the rural emergency hospital opportunity. And then we brought on a consultant to actually run the financials. So we did not use the financial assistance evaluation part from the Technical Assistance Center. We had already done that before we engaged with the TAC. So we brought on that and we evaluated again and found that it would be beneficial from a financial perspective in order to be able to continue viability of our facility. We also, of course, looked at other things in terms of the clinical services we have been providing. One of the things we noted was 90% of the patients that we see in the emergency room in our Von Terre facility are returned to the community. So only 10% required an admission or a higher level of care. And with that, because of the types of services that we did not have at our Von Terre facility, but we provided at our other sister facility nearby, we were transferring a high percent and admitting very low numbers at Von Terre. Von Terre is a unique size facility. The minimum size in the definition of a hospital in the state of Missouri is 3 inpatient beds, and that's what we were. So it wasn't a large inpatient population prior to our conversion. So that was part of our decision-making process. And the ability to continue our other outpatient services was an important part of it as well. So we looked at what were the needs for our community.
Thank you. Thank you. Aaron, can you walk us through your decision-making process?
Thank you, Anna. Yeah, our conversion process really started almost 3 years before the REH even became an official designation with Medicare. The individual who is currently my board chair was at a state hospital association meeting and heard a presentation about some things that were coming down the pipe. And it wasn't known as REH yet, but they had a model that they were working on. And he said, I wonder if that model might work for our hospital someday. And so that's really where that initial thought, that seed was planted. We continued to watch the REH model as it went through the legislative process, as it became an official Medicare designation, and really kept a close eye on our financials, which honestly over the last 10 years had been slowly declining. And we looked at statistics from 2017 through 2023 fiscal years, which was really where we made that decision to convert. And just like Annette was describing in their situation, so our average inpatient census had dropped from 4.5 in 2017 to less than 2 in 2023. And we also had a very high percentage of our ER patients, it was over 90%, whose needs were able to be met in a treat and then discharged to home or discharged back to their institutional living arrangement without needing an inpatient admission. And we are less than 30 minutes from 2 other PPS hospitals that both have ICUs, that both have OB services. And so we felt like those needs of those patients were able to be met, and really engaged in those first couple years as we saw the hospital's financials really steeply declining coming out of COVID. We were engaging our medical staff. We were engaging the community foundation board in our town to talk about what is the long-term financial sustainability of the organization. And upon reviewing the information that we had internally, having this conversation about what care we were actually providing, all of the involved parties felt like the REH model was a good fit. I remember the board meeting. We actually had supper at one of the board members' houses. All of the board was together in the middle of June 2023, and we had a vote at the end of that on a short board meeting to move forward with participating in cohort number 2 with the RHRC TAC. And so we joined in July 1 of 2023, and were able to participate in the financial modeling, which presented a very clear financial benefit to our organization to convert, and really aided in our board making that final decision to apply.
Thank you, Aaron. Can I ask an additional question? The financial modeling period that you went through, did that take a period of time for you to get to a point to make a decision, or was there a clear impression from the initial model that demonstrated a benefit?
The initial model that would have been provided to us by the Mathematica group was very clearly beneficial. I think it only took, we considered that information at one board meeting, and within a month, the board was ready to vote to make a decision to move forward with conversion. So it really was a fairly straightforward decision for us. We were a PPS hospital prior to conversion, and so that made that financial analysis much simpler than it would have been if we would have been a critical access hospital, because we weren't receiving 340B previously. All of our inpatient stays would have been paid under the PPS DRG system, and so the financial modeling was simpler for our facility.
All right. Thank you for that.
Yeah.
So we do realize that a change of this caliber can be quite upsetting and a very sensitive conversation with some of your stakeholders and your community members. So I'll ask each of you to answer, but how has the community responded since the conversion, and what kind of community education did you provide during the process and after the process to make sure that a true understanding of what the rural emergency hospital could provide was out there in the community?
So I'll start with our process. So when we had internally made the decision, we knew that we needed to engage our stakeholders. So the first thing stakeholder I engaged actually was our mayor of Bonne Terre. So I invited him in. He was a fairly new mayor to the community, and so I invited him in. We did a tour of the hospital. I talked about all the different aspects of the care that we provide, and then the opportunity that the rural emergency hospital would provide to us as a community, and providing for that sustainability of the services in the community. And he was quickly one to adopt the concept that it was a positive thing for the community. From there, then we engaged in several different business organizations, as well as our hospital auxiliary, who people were very passionate about the healthcare that we provide and our hospital. We engaged with them and educated them on it. So they were kind of a voice into the community for us. I went to the city council and presented to the city council, and it's a obviously public event. So the public was there, and I was able to share education there. And then we hosted a chamber after hours at the hospital as well, and then explained to the chamber members what this was, what this meant to the community. And so that was really kind of how we initiated our communication into the community, by going to some of these key stakeholders who were, if we had them understanding it and supportive, would help us be a voice throughout the rest of the community.
Very good. Thank you. Aaron?
I really like the thought of engaging key stakeholders at the beginning, like Annette just touched on, and that was essential for our position. We're a small community, less than 3,000 members in the town of Mound Ridge, and so everybody knows everybody. Everybody knows what's going on, or at least they think they do. And so more on that later. But we had really engaged our emergency medical services, our EMS service, which is a city-owned service in our community, our medical staff, and key stakeholders, and had conversations with them before we really went public about what the hospital was doing, because we wanted to make sure that those key stakeholders were on board, understood the key reasons why the hospital was making the change they were making, so they could be a voice for positive change instead of adding to the negative storylines that we knew were going to come out. You're always going to have some people that are unhappy with the change. And so I think that was key for us. We did engage our patient family engagement committee at the hospital. Once I had talked to the medical staff and the board, they were the next group associated with our hospital that I sat down and shared the data with, the financial benefits to the hospital. And then we are able to, in a sense, kind of deploy those patient family advisors back into the community as they interacted with their friends and neighbors at the coffee shop, at the senior citizen center. They could once again help to answer some of those questions. And then in October of 2023, right before we officially applied, we had a community town hall, and we had a very, very good representation of community members present, including staff and board members from the hospital. And I felt like a key part for the community of Mound Ridge was when the question was asked by one of our leading members of the community, what do the doctors think of this? And the president of our medical staff was there at the meeting that night, and he was able to stand up and say, as physicians, we have reviewed this. We understand the reasons why the hospital is making this change, and we can support this 100%. And it's like after that, the community was done asking questions, because this is an individual that's been a physician in our community for 30 years, and they trust him. Now, that didn't mean that's where the questions stopped. In the first year post-conversion, I would say the first 3 months. So we converted January 1 of 2024. And from January to March, we had quite a few questions. Our ER volumes dropped off substantially, and we heard in the community some people were saying Mercy Hospital has closed. I was able to do presentations at both the senior center and one of our senior living community complexes, and in both cases I was invited to come address some of the rumors people were hearing about the hospital and really provide accurate information that helped calm their fears. And we have seen our ER volumes rebound basically back to what they were pre-conversion, in addition to adding services, which I think we'll maybe touch on later here. But overall, the community response has been very positive.
Fantastic.
One of the other major events that we had in order to support it for the community was, I'll talk about this later when we talk about one of the other process, but we had to create the bill for a rural emergency hospital to exist in our state. And the governor signed that bill in our hospital. And it was a very engaging event in which a lot of community members were invited to, and we're very proud of the fact that we had the governor. So the idea that the governor was there supporting us was another selling point for us in our community.
Yeah, that's very cool. And I'm looking forward to learning more about that from you, and that very good. So would you be able to share with us how this transition has been beneficial to not only your facility, but to your communities that you're serving? So we'll start with you in that.
So, it really goes back to having that sustainability of healthcare in your community. We all know the risk that our rural hospitals were in and continue to be in today. And so we really needed to be able to identify how we were going to do that. So Bonterre, and I'm in two hospitals, but they're both called Parkland Health Center. So Farmington and Bonterre, we're sister facilities. And we had already worked through what were the appropriate services we should have at Bonterre versus what we should have at Farmington. So Aaron had mentioned before about the 340B. Our Bonterre facility was not 340B, so that was definitely a positive for us. It didn't matter in terms of our ability to provide that service because our Farmington facility is a 340B facility. But we really looked at it from our ability to continue that services. So that was the main focus of it. But the second piece is we actually are expanding our emergency services. We incorporated the area that was the inpatient area actually was sat next to the ED. And so now it's actually all part of the ED. So prior to conversion, we cared for a lot of patients in the hallway just because we didn't have the capacity and the space. So this has actually enabled us to move people out of the hallway and actually into rooms to be able to be cared for. So that was definitely an enhancement. And then with the consistency of the payment, we've actually been able to look at how do we do upgrades. So matter of fact, today, we are kicking off a CT replacement. This required us to bring in a mobile CT so that we could take the old one out, put the new one in. So we have had a 4-slice CT at that facility. I don't even know how long it's been there because it was definitely in need of replacement. But that opportunity from a financial ability to replace that CT was an important part of it. So we're upgrading to 128 slice. And within about 14 weeks, that will be completed. So very excited about that. And then we are also doing some redesign of the emergency room and incorporating more space that was not being used by the emergency room into the emergency room. So again, that is truly what we are enhancing what we're able to provide from an emergency service. We also, with the change of not having the inpatient nursing staff, we actually added nursing to the ED staffing pool as well. And so we have additional nurse on every day beyond what we had before. So that actually increases our response time to our patients in our community. Our other outpatient services have continued. But then we have a clinic that's attached to the hospital as well. It's part of the hospital. And we have actually started adding more services there. We've added another primary care provider. We now have our orthopedics providing outreach to that community from our other communities. So we're definitely enhancing the care that we're providing in the community.
Very good. Very exciting. Aaron, how about you? Can you share how this transition has benefited your facility and your community?
So the number one positive change for us has been that our organization for the first time in the 8.5 years that I've been here is actually in a stable cash flow position. It's been very wildly all over the board from a couple years during COVID where things were covering their expenses, not that we were making money hand over fist, but the combination of more acute care patients and some of the COVID helped to offset some losses during that time to in excess of $1.5 million losses. And we were thankful to have a faith-based community. Our hospital is actually owned by the Mennonite church, and that church stepped up and even held love offerings to help keep the hospital open during some of the lean times. But as of right now today, our hospital is in a positive operational position. which is a tremendous accomplishment for our community. And Annette touched on upgrades necessary. We've had some life safety things that have been deferred, unfortunately, because of cost for a number of years that we're finally being able to address. And that's really where we put our priorities on necessary life safety upgrades within our facility, sprinkler systems, and those kind of things, fire doors, smoke systems. So we do definitely have plans if things continue to go as they have been. Due to the operational improvements that we've made by closing the inpatient unit, we no longer have the cost associated with maintaining that unit, and so that has allowed resources to be available to help make necessary improvements. We've got a piece of lab equipment that's going end of life later this year. We're going to be able to replace that piece of equipment. And 3 years ago, I would have told you, well, we'll probably go aftermarket on maintenance agreement and try to see if we can keep that thing going as long as we can. Well, we're now going to be able to replace that instrument that's at end of life. So that's a tremendous positive for our community. We're able to say with confidence that we have the equipment and the services to better meet their needs. We're providing training and education to our staff to better allow them to meet those patients' needs at the bedside, because the acuity of our patients is actually going up compared to what we were seeing pre-conversion. So
very interesting. I have to ask, I'm assuming that your staff engagement and satisfaction may have gone up as well. I know getting new equipment always makes people happy, but can you talk a little bit about your staff engagement and satisfaction? I know I'm throwing that out there, but I'm just curious how you both feel about that.
Yeah, I'll take that one first. And our staff, we just completed a employee engagement survey, and across the board, our scores were 2 points higher on a scale of 1 to 10 for nearly all the questions than they were when we last did our employee engagement survey in 2023. So I think definitely better job satisfaction. Our managers are getting their performance reviews completed in a more timely manner. We've had better and more timely raises given, to our very deserving employees. So we're very thankful for those things, and they definitely contribute to employee satisfaction.
Good.
Yeah, our employees are very dedicated to the community. So the idea of having the sustainability was really important to them. And honestly, the reduction of hallway patients has been one of the things that improves their satisfaction. One of the challenges, though, I will admit we do continue to have from a staff satisfaction perspective is the increased intensity of workplace violence. So that is a challenge that I think that we are seeing across all of our organizations, and that is a worry often for our facility because it is a small facility. We are kind of in the middle of nowhere kind of concept. So the idea of the increased workplace violence and how do we support our staff has been one of the employee engagement activities that we've had to enhance since this.
Yeah, very interesting. Well, thank you both for answering that question. That was just an interesting aspect of what happens in a small place when you get new things and they sense a sense of stability. So thank you. All right. So Annette, how have you adapted your emergency and outpatient care delivery to fit the REH model? We know that REHs can have multiple outpatient service lines. And have you implemented any new outpatient service lines since becoming an REH?
So we have not implemented any new at this point. We have been evaluating opportunity. One of the challenges we have is the space in our facility. Because we took that inpatient incorporated into the ED, that was the extra space that we had. And I mentioned the remodel that we're going to do with other areas to incorporate that in there. So we have a small area that we have opportunity for additional services, and we are evaluating what those will be after we do the remodel that's going to be taking place. So Aaron mentioned getting new lab equipment. We got new lab equipment this year. We're getting our new CT. We're going to do this remodel and then the additional services. So we have had the opportunity to sit down with the Technical Assistance Center from their service line review process and identify where are our best opportunities, recognizing that as they look at what are the out migrations that's occurring from that community, mentioned I have another facility nearby, so I also look at what are the services that I'm providing in that facility, and then what makes the most sense. So we've been working through what we think are the next opportunities for that community. I would love to enhance behavioral health, but that is also a challenge to do it as well. So we've got a couple things on the table that we're looking to enhance, but just to focus on the sustainability and the enhanced services of what we do provide.
Very good. Very good. Erin, how about you? How have you adapted your emergency and outpatient care? And have you implemented any new service lines?
So Annette just mentioned behavioral health, and while it's not a service line that we are specifically billing for, we have partnered with a community counselor who provides mental health services. And then her daughter just recently graduated from school and has joined her practice. So we have two um, mental health counselors that are providing services. They're renting space that used to be our inpatient unit, and their patients are using the main entrance of the hospital to come in. And so it's just been a positive interaction. All of the comments they've provided and feedback they provided to us is thanks for being able to provide them the space. They've wanted to have more of a presence in the community and have more space for appointments. And so that's one way we're able to meet what I think any of us in healthcare would say is an increasing need for those behavioral health services. So that's been one positive. The biggest change that we made from a service line perspective post REH conversion was the opening of our walk-in clinic. And so that's been a very nice complement to our emergency room. It's open 5 to 8 p.m. on weeknights, and then 10 to 4 on Saturday, and 12 to 4 on Sunday. And so we see about 50-50 patient volume on the weekend. Those 2 weekend days see 50% of the volume, and then the weeknights, the other 50%. But that's been a real nice complement and has allowed us to reach the needs of a patient population that previously was not really utilizing our hospital. We were serving primarily geriatric patients from either independent living or an institutional living setting within our community. And so now we're be able to see more patients that are either those working adults or even families with young children that can come in after school or after work and be seen by a provider, in some cases even before the pharmacy closes. And so they can get a prescription yet that day that they needed to avoid decline and further hospitalization potentially. So that's been a big positive, and we're looking at some additional utilization of our other space that was inpatient for outpatient infusion, which is a service line that we've expanded significantly, almost 100%, or basically double volume in our outpatient infusion since we converted to REH, and really picked up a service line from our local clinic that they were unable to sustain because of staffing. And so it's given our nursing staff that we have here at the hospital something to do, allowed us to retain nursing jobs in the community and meet a need so that those patients didn't have to drive elsewhere for services.
Very good. Very good. All right. So we have a lot of tools here at the REH Tech. So I'm just curious if there were any tools provided by the REH Technical Assistance Center that really helped you all identify service lines or potential opportunities in the community.
So yeah, I mentioned we sit down with the Technical Assistance Center team and review their service line evaluation tool, looking out at outmigration and what are the opportunities. So we did use that. Obviously, that's been our most recent support. Prior to conversion, though, we actually used a lot of the other resources that were available. So when we talked about all that community education, there was PowerPoint samples and information that was provided by the TAC that we used. And also the actual conversion action plan. They had great examples of that. You have to have the transfer agreements. So we had examples of that, which fortunately we had some of those in place, but just verifying that we had what we needed for this application process was there. And then just the whole, here's your steps you need to take. It was so helpful to know what steps we needed and helping guide us through those steps. So we used a lot of it from the conversion perspective. And then most recently, the strategic planning. We do participate, I think pretty much monthly, in the group and love the learnings we get. We get to hear about different quality ways we need to approach things, making sure we're meeting the regulatory compliance perspective. There's just been a lot of great education, and just that opportunity to be on the conversation with other providers, understanding how did you approach this, how what are your opportunities that you've thought through. So just the whole team concept or the collaboration concept has been very helpful to us.
Very good. Great to hear. How about you, Aaron?
Yeah, I would echo the team collaborative benefits, what Annette was just talking about. That's been a huge benefit to our organization. And I think we've utilized resources from the TAC all the way through to current, several that really jump out. We did a leadership engagement and education process over a number of weeks with my leadership team, and they continue to talk about that, the lessons they learned from that. And I feel like it was a big morale booster for all of our departments. We had come through some unexpected bumps in our REH conversion, and some people were questioning whether it was the right decision for the hospital or not. I think we've solidly landed on the side of yes, it was a positive for the community, but it really came at a nice time to really build our team. And the service line assessment, or a service line inventory assessment, we have begun using that to look at some potential service lines. At this time, our board is prioritizing bringing back some services that we understand are an option under the REH, but may require some additional legislative changes. And so we're kind of keeping our cards close to our chest at this point in time with putting too much money out and bringing in new service lines, because we want to be able to pivot quickly if those things come. But we have definitely identified 2 or 3 service lines that our community could benefit from. And we've been able to take that information from an outside assessment tool and then go to our medical staff with it and say, what do you think of this idea? Does the patient population that you're seeing and experiencing, do you see these needs in your patient population also? And when we've been able to say, yes, there's a match here, the service line assessment inventory said, yes, we could use this, and the doctors say, yes, my patients could use this, then that's a win-win. It's validation that we're headed the right track. And we very much appreciate that. Thinking too of the initial financial analysis, that was very helpful for us as I was having conversations with our bank, as I was having conversations with our financial auditor and our cost report preparer about our REH conversion. We had independent third-party numbers that weren't just coming from me, that I could use to back up my statements that this transition is going to be financially beneficial for the hospital, and really, like on the part of the bank, encourage them to give us a little more time to get things turned around. So I tell everybody I can about how helpful the RHRC has been to us as an organization that is a rural emergency hospital, as an early adopter, helping us see ourselves as pioneers rather than guinea pigs on moving forward with this new model that I feel like is more sustainable for rural healthcare.
That's wonderful. Thank you so much. All right, Annette. Now we know that there's some fears out there about conversions to an REH. So what were some of the biggest unknowns or surprises that maybe you experienced through the conversion process?
Well, our first situation was our state did not have the right licensing capability for a hospital to become an REH. So you could be a critical access hospital, you could be a PPS hospital, but you couldn't be an REH. So that was actually one of the people we engaged early on was our legislators, and sat down with them and talked to them. This was even before we had some of the other conversations, and said, okay, here's something that's coming. We really think this would be good for the state of Missouri, and we'd like for you to assist us with getting legislation. And so our local legislator immediately took it up as his thing to do. He was going to get that accomplished. The challenge we had in getting that done, though, was that was a year of many healthcare considerations in our legislation, as well as some other controversial legislation. So it was often a it's on, it's off, it's on, it's off kind of process. And the Missouri Hospital Association was assisting with us as well, but they also had to look at the entire MHA platform in terms of what they needed to support that year, and say, okay, can we continue to make this something that's priority versus we have to have something else. We got very fortunate in that our bill, which was a very short, simple bill, became the ombudsman, I can never say that word right, bill for all these other things, because they knew ours was one that was simple and there was no reason why people wouldn't agree to it. and started attaching all these other concepts to it. So our bill ended up being a very large bill. And but it did pass because of that. So that was actually one of the interesting parts, was going through that legislative process with both our legislators and with Missouri Hospital Association, and how we had to navigate that to happen. So very exciting to have that to happen. So that was our first probably big thing. And then actually the application process. So we were, like I said, assisted quite well from the Technical Assistance Center on how the process should flow. But just the idea of, again, we were the first in the state. So did we did the information get to where it needed to go? And then you sit and you wait and you're like, okay, is it getting processed? Is it not? So you're kind of pinging people to say, is it there? Yes, but now you have to wait, so you really go through this process of that. And then when we had chosen January 1st as a transition date, just for all the things to make things easier on your cost reports. You don't have to do 2 cost reports for the year, et cetera. You get to, hopefully make your transition on that date. Well, we were notified on 12/27 at the state level that it was going to get approved, but we didn't have all the final information from CMS to say this is your date, this is your numbers, et cetera. But kept being told you will get to backdate to the date you gave, that we approved, et cetera. So, going through that process and making sure that things were truly going probably was one of the more challenging components of it, because you got a little nervous thinking, I've committed to this. Is it going to make it through? So we got, I said, December 27th is when we notified by the state. And then it was mid-February when we got our final numbers to be able to allow to transition the billing. So we had to hold bills from January, and actually it was March before we were able to start processing bills. So that was, some of the bigger challenges and things we weren't really sure what to expect, and how the state would respond. But our state was Department of Health and Human Services was very, very helpful to us and very supportive, even helping us to make some of those connections to the CMS regional office, and, working us through, helping to make us get through. We had questions about, the facility and the licensing and all, and just things like that, but they were very supportive to work through. And so that was really kind of our major components that were kind of curiosities to us through the process.
Yeah, very cool. Very good. And you said the governor came and signed the bill at your facility.
Yeah, and so because it was that omnibus bill, there was things about Parkinson's research in it. There was some things about advanced practice nurse licensure levels, and so we had all these other people. So I said it was really quite the event when the governor came, and we had a huge community event for us to have quite that many people show up at our facility. It's a small facility, so we were a little struggle to get them all in, but it was quite the event to have, and so very proud of the work that we did. Something just this will be an emotional tag for you. Prior to our conversion, we actually had one of our local police officers who had been shot in duty, had been saved in our ED, and he came back for his first day of duty that day and was at our signing. It was pretty emotional.
Very nice. Very nice. Thank you for sharing that. Very good. Erin, if you could share with us some of your biggest unknowns or surprises, and then I'll tack on a little question to that. If you had a magic wand that could change some of the REH statute, maybe you can share a little bit of what your thoughts would be for that.
Yeah, so for our organization, and going back to the community town hall, one thing we told the community, because we'd understood it, was the allowance of those skilled nursing services in a distinct part SNF. And I attempted to have as many conversations at the state office of health, at the CMS regional office, reaching out to my contacts, hospital association. Everybody understood that we had what would be needed in order to continue providing skilled nursing care in a distinct part SNF. However, somewhere along the lines, the information that our SNF had officially closed, CMS never provided that letter to me until after we converted to REH. It wasn't in my file for whatever reason. And so we had converted with the understanding we'd be able to continue operating our SNF, and found out that actually, no, that CCN had been rescinded. And now we would be unable to operate skilled nursing moving forward until we were able to go through a separate and distinct licensure process at the state level, which has not been completed yet. We were able to work with our state legislature last year and get a bill passed that will hopefully allow us to begin moving that direction again. But if I was to wave that magic wand and make one change, I would like to see legislation at the federal level, and our state senator Jerry Moran has actually introduced a piece of legislation that I personally would support. They've kind of affectionately dubbed it REH 2.0, that would actually allow for rural emergency hospitals to provide skilled nursing care in a swing bed capacity. And the difference between distinct part SNF and skilled nursing might be lost on some populations, but there's actually, I did a rough analysis, and for our organization, it would cost us over $1 million a year more to provide skilled nursing in a distinct part SNF because of all of the redundant and unnecessary legislative hurdles and barriers that we put in place. So we're definitely in support of that. And if I was to wave a magic wand, it would be to make that legislation effective today. We had a call with Senator Moran the other day, and we're encouraged that hopefully he's going to be reintroducing that legislation soon. And we would definitely support that as it moves forward.
That is very encouraging, and thank you for sharing that with us. So, Ned, I'll come back to you. I didn't ask you the question, but if you had a magic wand, what would you like to see changed?
So actually for our Von Terra facility, it has been an ideal opportunity. However, I do know that I have other facilities within our state, in our neighborhood that really could benefit from it. One for the swing bed, as mentioned by Aaron, but also for the 340B. Because I do provide my oncology program at my Farmington facility, and that's where I have the most impact of my 340B. I haven't had it as a necessity for Von Terra, but I know in conversations with other rural hospital presidents and leaders here in our area that the 340B impact is important to their community, and it currently in some cases it outweighs the stipend payment that comes through the REH.
Yeah, thank you for that. Both very important. I'm going to wish that you both find a magic wand, because I think that would be wonderful for a lot of hospitals across the country, to be honest with you. So how did the REH TAC help you on the journey? I know you've both mentioned a few things. The REH TAC does provide both pre-conversion and post-conversion support. So have you found the post-conversion support as beneficial as the pre-conversion support?
I would say yes. As we've kind of talked a little bit throughout this conversation today, the group that we get together and talk to each other has been a great support. But also just the education that we have the opportunity to have. So we had a conversation or an education one day on observations and the process for observation patients, and then we had a compliance regulatory overview and update. So, you think you're doing all the right things, but it always helps to get the education, and then you're able to revalidate it. We've actually continued. So the action plan that we created before, we have actually continued through that, monitoring it and identifying, okay, how is this going? Is this process working? And then we also, we are submitting quarterly data to the TAC, and then they're gathering that and allowing us to compare ourselves to the other organizations. So it gives us an idea. We're not comparing ourselves from a competitive perspective. We're comparing ourselves from are we doing everything right perspective? Are we getting things in the way we should? Are we caring for the community the way we should? So it has really been a very beneficial support network for us.
How about you, Aaron?
Yeah, and I would just say simply, I think the post-conversion support has probably been even more valuable to us. We welcomed, and I was very thankful for all the support we received pre and during conversion, just reviewing documents and helping us understand what the conditions were so that we could make sure we were in compliance at every step of the way. But I think the post-conversion support for my team has been invaluable, helping us not feel alone in this process. You mentioned earlier, Anna, that there's 41 hospitals that have officially converted out of, what is it, almost 7,000 hospitals in the entire United States. So that's not a very big peer group, but I feel like we've been able to build a cohesive group that does support one another, and that's been very important.
Thank you both. That's fantastic to hear. So looking back, would you have done anything different during the REH conversion process?
I don't think that we would have done anything different. We couldn't have done it a minute sooner because of the state licensure issue. I think that's probably the first answer is I would have gone a year before, the first year is available because I was in year 2, but I couldn't have because of my state. So I can't say there's anything I would have done different.
Okay. About you, Aaron?
Going back to the question we talked about a few minutes ago about the magic wand and, that whole surprise for us, knowing what I know now, I would have done that aspect of the conversion differently. There's probably steps I could have taken sooner that would have, prevented us from having the bumps in the road that we did have. But that would basically be the only part of it. I mean, really, all things considered, with it being a new model, we were working with our Medicare administrative contractor, our state Department of Health, and the CMS regional office. It was, for them, only the second REH application. And so everybody was pretty new at the process. We were all kind of learning together. And I don't fault anybody for some of the answers that I got that were maybe not as clear as they would have liked to provide to me, but we were all still trying to figure out exactly what this meant when the rubber met the road, because it was all still pretty new. So
yeah, well said. Well said.
Something that I thought of.
Sorry.
When you think about too your reimbursement levels, because the 105% is for your Medicare. So what is your state Medicaid reimbursement going to be? Is it clear to you that you're going to get a certain level? So I think that's something for people to be aware of. And then also, even with your insurers, so if you have contracts with insurers that were paying you at a critical access hospital rate, what are you going to get under the REH? You need to know that. And then amazingly, in our region, TRICARE was not ready to accept payment to us as a rural emergency hospital. We have worked through that now, but that was something that actually, I said we didn't get to bill for 3 months. Well, TRICARE wasn't prepared to pay us for another 6 months because they didn't have the right electronic systems to accept our bills correctly. So there was some things like that you need to be aware of as well.
Yeah, thank you for that advice. I was just going to say, I'm sure there are people listening that could really benefit from some additional advice if they're considering an REH, or if they're a state office of rural health and they know of a hospital that possibly could benefit. So any advice that either of you, additional advice you would like to give, would love to hear it.
I would just add support for what Annette just said about all of those billing aspects and contracts. Your commercial insurance companies may be willing to continue your existing contract, or they may not. But I think having those conversations as early as possible in that process, so that as an organization, you're prepared financially. We all know that contracting is one of the biggest hangups to getting paid correctly for services. And so, getting your providers enrolled, are there changes that are going to need to be happening when you're changing Medicare designations? You're getting a new CCN. And so now all of those ERA, the electronic remittance advice, and electronic funds transfer payment systems have to change. And so there are going to be barriers and challenges with that. So, knowing those things up front going in, I think helps a facility be the best prepared for conversion, even just thinking from a cash flow and operational perspective.
I think that having a comprehensive team is very important. So this isn't I did this myself concept at all. This was truly a team with my compliance team members, my nursing caregivers, my financial team, my RCM. So it is truly a team effort. And I think that's important, that you make sure you've got all the people on the team you need on the team.
Very good. Well, thank you both so very much for being with us today and for sharing your thoughts and your ideas. I'm sure that it's been beneficial to our listeners, and we are thrilled that you're part of the REH TAC post-conversion program to really help continue to share your thoughts and your insights so that other hospitals exploring the REH get the information they need to make the right informed decision. So thank you again. I'm going to turn it over to Amy to discuss resources and next steps. So thank you.
Thank you, Anna. As I mentioned earlier, these slides will be made available, and included in that we have resources and links. We've consolidated a few things that we thought you may be interested in exploring further. And this is just a reminder that you'll be able to find all of this information, as well as the recording to this webinar, on our website within a week after the event. If you don't already follow us on social media, I encourage you to do so. We routinely post information that's not only relevant to rural communities in general, but specifically to the rural emergency hospitals. You'll see our website listed here, and we welcome you to reach out to us at any time if you have questions. Thank you for joining us today, and a special thank you to Aaron and Annette for taking time out of their busy schedules to share their experiences with us, and a special thank you to Anna for her presentation. Have a wonderful afternoon.